This week on the BackTable podcast.
At least half of individuals, by and large, are going to have some serious side effects that you can definitely chalk up, not to disease, but actually to the treatment itself. And these are side effects like fatigue, hand-foot syndrome. You might have bleeding and clotting-related issues, diarrhea, liver function test abnormalities. These are real potential showstoppers when it comes to treatment for the patient. Having said that, again, I will say that these treatments tended to be something that would be tolerated by a broader pool of patients than something as aggressive as IL-2.
Hello, everyone, and welcome back to the BackTable podcast, your source for all things urology. This is Aditya Bagrodia as your host this week, and I'm very excited to introduce our guest today, Monty Paul from City of Hope. Welcome to the show, Monty. How are you doing today?
Aditya, it's great to be here. Thanks so much for having me.
Well, it's a pleasure, Monty. I've admired what you've been able to do in so many of the GU cancers. Actually, the work that you've done here in Southern California, really kind of uniting and allying all the various institutions down here is truly phenomenal. You're a mover and a shaker, and it's really a treat. So today we're going to talk about kind of perioperative therapy for kidney cancer. And I thought it might be useful. I feel like we're roughly in the same vintage. If you maybe took a little walk down memory lane from when you were a fellow, early attending, kind of what role, if any, neoadjuvant, adjuvant therapy for kidney cancer looked like, what kind of tools were available in your toolkit, and I bet that'll lead us into the conversation.
I think that's a great place to start because I'll tell you, I began as an intern in 2003. And at that point in time, I distinctly remember being on the medicine wards, taking care of a ton of patients with advanced kidney cancer. And literally the only therapy we had at our disposal that anyone would use consistently was high-dose IL-2, So it's such a different era in the disease. And as we know now in retrospect, the response rates to high-dose IL-2 are modest at best, maybe on the order of 10 to 15% at most. And amongst those, you really only get small subset individuals with a long-term response. So it's definitely not the type of therapy you'd think of as a preoperative or neoadjuvant treatment. And certainly from the standpoint of toxicity, putting the patient through this drug that has this massive risk of arrhythmias and other significant cardiovascular complications, it's nothing you'd ever want to attempt in a preoperative setting where a patient ostensibly could be cured of their disease, right?
Totally. And, maybe as an extension, it was basically upfront cytoreductive nephrectomy for everybody unless they were literally about to die. IL-2, if there's any way in God's green earth you could administer it because it was the only option with a potentially curative intervention. And boy, have we changed. So couldn't agree more. There's basically nothing happening neoadjuvant, not even kind of a conversation because the tools in our toolkit were so limited, and post-operative adjuvant, again, wasn't really a conversation. Then maybe we fast forward 5-10 years. What does that look like? Early, 2010-ish.
Yeah, no, it's a great question. When we get to the 2010s in the metastatic setting, we started to sort of tinker around with tyrosine kinase inhibitors. It became a real, I would say, huge addition to our frontline armamentarium for treating RCC. So drugs like sunitinib, sorafenib, pazopanib, those are the ones that had become a standard of care at that point in time. And I really think when we started seeing a drug that could be maintained, albeit with some toxicity over time, we started to think to ourselves, gosh, this applies to a broader swath of patients. Maybe there's potential here for a drug that could be used in the preoperative setting consistently as a means of downsizing tumors.
Yeah. When I think about it kind of from the urology lens, it was relatively uncommon cases, solitary kidneys, big masses, bilateral tumors, tumor thrombi that you're trying to downstage just a bit to decrease some of the morbidity of the operation. And the data was okay. Is that how you kind of see it?
Yeah, okay is, perhaps a little bit of an overstatement because we really didn't have big randomized trials at that point in time. But I do think that investigators started thinking to themselves, gosh, maybe outside of this preoperative context, we could start using these drugs in the perioperative setting, maybe apply them in adjuvant trials. And that's really what I think the first sort of group of adjuvant trials began to become formulated and implemented in the clinics. And those adjuvant trials, of course, still have implications for our treatment today.
I guess when I say okay, I think the data quality was okay, largely single institutional or multi-institutional retrospective studies where you're kind of using this off-label, but also the impact was modest at best, maybe like a 20-30% of patients that are having a decrease in their thrombus level or that made partial nephrectomy more amenable. So nothing that I think the community from either end was super stoked about. And the side effect profile was not trivial. I remember as a fellow rotating through Bob Motzer's RCC clinic, and the folks coming in on TKIs, they were pretty banged up. Like, this is not like a, walk in the park.
Oh, 100%. When you look at the clinical data that we've amassed since then, and you could look first to the phase 3 trials, for instance, that led to the approvals of sunitinib and sorafenib as monotherapy, you've got about 40 to 50% of patients at the very least who have grade 3-4 toxicities that you can clearly attribute to therapy, right? So, at least half of individuals, by and large, are going to have some serious side effects that you can definitely chalk up, not to disease, but actually to the treatment itself. And these are side effects like fatigue, hand-foot syndrome. You might have bleeding and clotting-related issues, diarrhea, liver function test abnormalities. These are real potential showstoppers when it comes to treatment for the patient. Having said that, again, I will say that these treatments tended to be something that would be tolerated by a broader pool of patients than something as aggressive as IL-2.
Completely. And in the metastatic setting, it's like a no-brainer, right? That was like a breakthrough that we have these selective TKIs. And then I guess if we're taking this walk down memory lane, circa late chief, early attending hood, you started seeing these larger phase 3 studies of adjuvant TKIs read out with some mixed results. S-Track, of course, was one of the positive trials. Did that get anybody pumped up on the medical oncology side in your perspective?
It's interesting because we have had a bit of the same experience in the immunotherapy space where we've had one study to date that really stands out as being positive. But I would say that, there were many similarities amongst a lot of the trials that were designed in that adjuvant space using TKIs, whether it's the ASSURE trial, whether it's S-Track, et cetera. All looked at a fairly broad group of risk categories, some ranging to as low as T1B patients. Everest, for instance, is a great example of a trial that took patients that were pathologic T1B and above, up to patients that were T4 with nodal involvement and so forth, and randomized them to a strategy of targeted therapy or placebo. We just had negative study after negative study. I just remember when ASSURE came out, we were all quite surprised that the adjuvant strategy of sunitinib or sorafenib, this was a 3-arm trial, really showed no benefit in terms of disease-free survival over placebo. The same was true for trials like SOURCE and others that looked at, for instance, axitinib in the adjuvant setting. S-Track really stuck out like a sore thumb in the sense that it was the one study, as you point out, that was positive. And this was a cleanly done trial. This was adjuvant sunitinib versus placebo. And the study did have benefit when it came to disease-free survival. Where I think the study fell short, though, is that there was no benefit in terms of overall survival. And I distinctly remember that when the data was published in the New England Journal, the disease-free survival curves were broadcast very clearly in the main text of the manuscript. The overall survival data, for whatever reason, was sort of, kind of turfed into the supplemental figures, right? So it wasn't alongside the main data. That's a little unusual, I think, when it comes to a manuscript of that caliber and magnitude. But it really drives home the point that, the study did lead to this DFS benefit, disease-free survival benefit, no OS benefit. And I think that the latter element, combined with the fact that we just had a readout from ASSURE not long before that showed no benefit with adjuvant sunitinib, caused a ton of pause in most people's mind around using the drug.
Yeah, when that came out, I was at UT Southwestern, tremendous kidney cancer program, and had awesome minds, Hans Hammers and Jim Bergolas, and on the med-onc side, tremendous kidney cancer researchers, surgeons, Vitali, Jeff Kadedu on the surgery side. And basically, it was a super highly motivated, generally young patient that really wanted to do everything under the sun to maximize their likelihood of obtaining some type of oncologic benefit that would receive it. But if I had to guess, 4 people that met the criteria to receive adjuvant sunitinib, maybe 5% at best. And back then, were you seeing patients? Were the surgeons sending you patients to, hey, Monty, can you talk to this guy about adjuvant sunitinib?
We've got such a great tradition at our hospital of referring high-risk patients into my practice. The surgeons that I work with, Clayton Lau, Kevin Chan, John Yamzon, Ali Zunkawala, now Wes Yip, who's a memorial-trained fellow like yourself, we actually had phenomenal paradigm in place where if a patient meets criteria potentially or adjuvant therapy, they come into my clinics at least for a conversation. Back at that time, it didn't really lend itself, just as you described, to a lot of patients actually getting adjuvant sunitinib at my shop. Having said that, I will say that it was a great way for us to sort of bring patients in for the next generation of adjuvant studies. And of course, those are the checkpoint inhibitor adjuvant trials.
Totally. And of course, we'll kind of dig into that in a big way. And maybe just some practical mechanics. Somebody coming in with a large renal mass, some nodes, some evidence of a thrombus. Are you generally seeing those patients pre-operatively, kind of to establish relationship, talk a little bit about what might come? Or is this typically happening after they've already received their nephrectomy, node dissection, et cetera?
It's a great question. I think that, again, our surgeons here, and I'm sure it's not dissimilar from your practice down there at UC San Diego, they have such a good radar for what a patient may ultimately need adjuvant treatment. Having said that, rarely do I encounter the patient before they go to the operating room. I'm usually waiting for that histologic diagnosis first. That's the one thing that, I might really sort of lean on heavily ahead of that decision for adjuvant treatment. Even if the patient has positive nodes, et cetera, getting that tissue first to establish that they have clear cell or sarcomatoid histology, I think is so vital. So direct answer to your question is no, I rarely see those patients before the OR.
Did you all have PROSPER or any of the neoadjuvant studies open at your institution?
Great question. We did have PROSPER open for a little while. It didn't really thrive at our institution. And I'll tell you what, we actually had a competing study open in Emotion 010, as we'll talk about later, but one of our sort of perioperative, mainly adjuvant IO trials. So I think it was competition from that study that really led us to shut down PROSPER.
Yeah, and for the audience, this was a hats off to the investigators, Moa Loff and Naomi Haas. To get an IAT of this magnitude off the ground is truly laudable. Basically, with standard of care versus a short run-in of single agent IO followed by adjuvant IO. And on the urology side, it was super exciting. We're starting to see this incredible data with immunotherapy in the metastatic setting, and I think we were all taking it as a foregone conclusion that it was going to be a positive study. That's just kind of how I feel myself and others thought about it. The mechanics were challenging. You had to get biopsies, which delayed things. Patients are getting antsy, maybe surgeon buy-in, kind of a lot of stuff going on. Inclusion criteria, easy enough to play Monday morning quarterback, but I feel like doctors were excited and the results were surprisingly disappointing from my perspective. What do you think?
Yeah, no, I've got to agree with you there. So, exactly as you said, the trial, was initially implemented with excellent intentions, and to the investigators' credit, when accrual was really sort of lagging behind some of the other adjuvant trials, I think they did their best to modify the eligibility criteria, right, to really accommodate. They shortened the duration of the neoadjuvant Followmab that folks would get going into the study. They became more permissive when it came to, other sort of histologies and strategies, allowed metastatic patients who were fully resected to potentially enter into the study. So I don't think they could have done more to try and make this study successful. I definitely think that, ultimately, this was just such a challenging study to pull off. And the negative result, I guess in retrospect, was largely derived from the fact that, we probably didn't do a great job of staging these patients going into the study, right? So many low-risk patients ended up finding their way into the trial.
Totally. I think it was, we all do it, right? You kind of laxen up the inclusion criteria so you can get more patients, and that kind of impacts the proportion of people who may see benefit, right? When we're looking at these high-risk groups, and I'm sitting down with somebody, running through their imaging with them, a patient with maybe some possible sinus fat invasion versus somebody who's got a thrombus and a couple of nodes. Those are both T3, but they're very different T3. And perhaps I could ask you, if you were going to be sitting down with patients on the front end and you're thinking about, their risk going into it, T stage, end stage, thrombi, those factors, and maybe we can extend it into the path features as well. What are the ones where you're like, kind of alarm bells are ringing that this patient's like super high risk?
Yeah, certainly nodal positivity, the presence of a visible IVC thrombus. I mean, those are the things that tell me that patient's going to be sitting back in my office post-op for a discussion. I think where it's a bit of a gray area, right, is when it's confined tumor, where we're not really seeing a lot of, perirenal and invasion and so forth. Those are the cases where even in a fairly large tumor, I think I've been prone to make a lot of missed calls when it comes to what their ultimate pathologic staging is. So I find it's really, really challenging, even I would say for the best of radiologists and the best of surgeons, to really make that definitive call around staging, unless there's really kind of obvious triggers around that.
Totally agree. I mean, pre-operative staging wise, it's going to be an adrenal met, it's going to be direct extension of the adrenal or the psoas, things like that, the thrombus, a node that you mentioned, that I actually think I'd probably have those folks see a med-onc just to kind of start learning about next steps. Let's just say that neoadjuvant's not really happening, so they can wrap their brain around, okay, I just had a big cancer diagnosis. I'm probably going to get a, well-tolerated but legit operation, and then there's a good chance more is to come. And, it's actually quite sobering to me as an attending when you follow these patients long-term and you're T3 and worse, the recurrence rates are not like surgery knocks it out 90%. You see 50%, 30% of patients, depending on risk, that relapse. And, that's disappointing, obviously, for all parties involved. How about with the path spec? You kind of talked a little bit about this. Let's just say that you're kind of chatting with them now in here's your pathology, you've recovered well. What are the features that really kind of get you on high alert?
Yeah, no, absolutely. I tend to be a purist there, and I know we haven't really, gotten into the weeds and some of the adjuvant trials, but I really just look across those eligibility criteria. And for anybody who meets the definition, T2 grade 4, T3 and up, nodal involvement, et cetera, those all are potentially eligible patients for adjuvant therapy. In my mind, it's so hard for me to parse out the data, and I agree that we could, kind of look at the subset analyses and tease out relative benefit. But when a study shows an overarching survival benefit and DFS benefit, it's really hard for me to argue that one subset deserves the treatment whereas another doesn't. That, to me, just kind of moves into that category of perhaps sentiment as opposed to evidence.
Totally. And I mean, sometimes when I talk about adjuvant treatment in general, I equate it to an insurance policy. It's like you're paying for something you hope you'll never have to use. And, by definition, that means a lot of people are overpaying, exposing themselves to toxicities, and they may or not benefit.
That's a great analogy. I'm going to start using that.
Well, that's it, right? We know we're going to overtreat people. We don't have the tools yet to say you're cured or not cured reliably enough to say you should or shouldn't. And, to person A, the benefit, let's say that they're at 20% risk of recurrence using whatever nomogram you want to, or if 80%, that 20% may be super compelled to do something, that I take out insurance policies for less impactful things. So I hear you. And, in the GU land, when you're talking about small renal masses, relatively lower risk prostate cancer, these are all conversations that I think we're actually quite good at, managing uncertainty, managing risk, and coming up with something that resonates with the patient.
Totally.
So I think it's safe to say, for like all practical purposes, adjuvant TKIs didn't really get anybody super excited. The value proposition was limited at best. Tons of excitement just based on the data for the metastatic setting for IO. Neoadjuvant, thus far, to my knowledge, there's nothing that's really come through and been kind of a game-changing trial, so to speak. So let's kind of talk a little bit more about, what all exists in the adjuvant space.
Yeah, as far as like checkpoint inhibitors go, right?
Yeah.
I'll tell you that it was first sort of a slew of disappointments. I'll say, that this first study that started up in this space was one that I worked on with Rob Uzo, Vaxil Bex. I briefly mentioned it previously, called Emotion 010. And this was a study of adjuvant atezolizumab, which is a PD-L1 inhibitor, versus a placebo. And, kind of standard design, similar to what you might see across other solid tumors. In the adjuvant space, patients got treatment for a year. These were high-risk patients as defined by T2 grade 4 status or T3, essentially an up. There were some other nuances around grading in our study. And then we had an M1 cohort. It's a little different from what you saw in the Keynote 564 study. We included patients that recurred beyond 1 year, as opposed to Keynote 564, which included patients that ultimately recurred within 1 year. My study was dead negative when it came to disease-free survival, overall survival, et cetera. And it wasn't the only one. We talked about Prosper earlier, also a negative trial looking at nivolumab. Checkmate 914, huge surprise to me. I was so surprised to see that particular study came back negative with adjuvant nivo-ipi, right? I mean, to me, it was just a shocker to see that this 2-drug regimen, which really resulted in so many durable remissions and advanced disease, really didn't do much to mitigate outcomes in the adjuvant space. It really was a surprise, but maybe in the end justifiable on the basis of toxicity. And then really comes along this study, Keynote 564, which, kind of changes everything. So this is a study that was led by Tony Chueri and Tom Powles and looked at 1 year of adjuvant pembrolizumab. And there was a clear signal there, right, of a benefit in disease-free survival. And what's perhaps more important, and what really I think sets this apart, and to me makes it a bit of a no-brainer, is the overall survival advantage. So the overall survival advantage here was just, really quite compelling. And in my mind, makes it, probably a de facto standard of care.
Yeah, I mean, it is. Backing up, the adjuvant ipi-nivo was also, honestly, it didn't make a ton of sense to me. Like, it sounds like perhaps to you as well. And maybe I'll just ask you if you had some hypotheses for why that relatively aggressive regimen we see added benefit to dual checkpoint inhibitor really didn't kind of pan out.
Yeah. I feel like this is one of those settings where toxicity really got in the way of treatment. If you look at the data, about 38% of patients discontinued therapy on account of toxicity, which is, pretty high number, in terms of getting to that 6-month landmark they were looking for in treatment. I would suggest that, it's one of those scenarios that proves to us that patients in the adjuvant setting are different. I don't think they have the same threshold for tolerating pneumonitis or colitis or hepatitis and so forth. I bet you a lot of these patients were started and stopped on therapy in a manner that reflects perhaps an earlier stoppage than we would have seen in the metastatic setting for good reason. And I do think that lack of dose intensity is probably what contributed to that being a negative trial.
So when we talk about adjuvant pembro, which I think the first New England Journal paper was disease-free survival, recently updated this year with overall survival. Maybe if you want to gear this down for a urologist or a urologic oncologist who's chatting with their patient either on the front end or the back end about what some of the options here may be, what's kind of hey, Mr. Johnson, here's what adjuvant mono IO looks like.
Yeah, absolutely. So the conversation with me always begins with, hey, chances are in the vast majority of settings that I see, the risks of recurrence are such that, there's a greater chance that you won't recur than you will recur, right? I'm going to start using the analogy of the insurance policy that you brought up, because I think that's a brilliant one to understand the fact that, certainly there's going to be some element of over-treatment when we do adjuvant therapy. But the conversation usually begins with a description of what the relative benefit is. And, I usually tell folks that there's a 30% relative advantage when it comes to disease-free survival. There's a benefit in overall survival that's perhaps a little bit more challenging to quantitate. And then we lead into a discussion around toxicity. And the numbers that I tend to keep in mind over there are 15%. And that 15% refers to the proportion of individuals that are going to have serious grade 3, 4 toxicities related to therapy. What I think is really important in counseling, and it makes it a little bit easier, I suppose, to counsel one on the side effects of immunotherapy, is, I usually just look at the patient in front of me and I say, look, there's a chance that amongst these 15% of folks who have toxicities, it could affect an organ system in your body that ranges from your head down to your toes. You can have cerebritis, you can have oculitis, you can have, issues in terms of cardiac function and pulmonary issues. So really any organ system can be adversely affected by really an overzealous immune response. But I also like to counter this by saying that, at least in my clinical practice, and this isn't true across the board, I've never had a fatality related to immunotherapy. It's because you can usually jump in early with the strategy of using steroids or some immune suppression to mitigate the toxicity. So with really careful follow-up, we can probably bridge most patients through the vast majority of toxicities that we see with IO these days.
Sounds totally fair. And, from our side, it's usually pretty dramatically different if they're getting, say, for instance, IO versus good old-fashioned cytotoxic chemotherapy. That patient looks like a different person. And yeah, I mean, I kind of stick it down to the itises. Anything that's like an organ in your body can get a little bit inflamed through the immune response. And I say about 1 in 6, so I think that tracks pretty well with what you're saying. And then it's once every 6 weeks for a year.
That's exactly right. Yeah. I'll just bring up one nuance there. You've got the option with adjuvant pembrolizumab of dosing it every 3 weeks or every 6 weeks. If I have a patient that I'm a little bit more worried about, right? Maybe they mentioned to me that based on their history, they got a touch of psoriasis, right? Not a severe autoimmune condition, but something that's mild that might potentially flare on therapy. I'll opt to follow them a little bit more closely. Or if I assume that it's a patient who may be a little less prone to report side effects to me, maybe a really kind of stoic young patient, right? I might say, hey, come in on that Q3 week schedule just so I can have a closer look at you. When we get out to 6 months or so, then maybe I can transition to the every 6 week dosing. But I do love to have that really early oversight over folks.
Totally. Makes sense. And, it's interesting kind of meeting people, large group practices. There's all different types of people administering IO. And for some of our larger groups that might be administering checkpoint inhibitors in your clinic on the urology side, this sounds like a pretty useful bit of intel.
Yeah, totally.
And for me, practically, usually like as they're convalescing, let's say they had staging, call it 4 to 6 weeks before their operation, they're convalescing for a month or so, I'll usually restage them top to bottom, CT scan, chest, abdomen, pelvis, just to make sure nothing's kind of blossom, some indeterminate non-specific pulmonary nodule doesn't look bigger or concerning. Well, let me ask you, is that something you typically do? And how do you kind of synthesize that information?
Absolutely. I think that's a really brilliant approach because, when you're seeing that patient for adjuvant therapy, we don't necessarily have a long trajectory of history with the patient, right? They might have gotten that one CT urogram plus, a distal to that CT of the chest, as the patient approaches the operating room. You have that one snapshot in time, and while that might be negative, you don't have any sense of the tumor kinetics. So, I think we've all seen cases where patient goes to the OR, then boom, just 3 or 4 weeks later, you do that baseline set of scans intended to really rule out any metastatic disease ahead of adjuvant therapy. You've got 3 new pulmonary nodules, right? And the management strategy changes entirely for that type of patient.
I mean, it's interesting. There's still so much that we don't know. Immunosuppressive effects of surgery, manipulation of the tumor, circulating tumor cells, all these things that could impact. But, despite being a surgeon, I think these are some real phenomena. Rob Svatek at UT San Antonio has done some very, very thoughtful work, say, for instance, in mice, where if you do just a laparotomy and a tail vein injection versus a straight tail vein injection, your uptake and dissemination of metastases is higher. So probably something going on there. Okay, so we're going to get them restaged. Any kind of biomarkers that you feel are heading towards or ready for prime time? Circulating tumor cells, cell-free DNA?
Yeah, no, thanks for bringing this up because I will say this is the one kind of interesting thing that came out of my trial, which is dead negative, Emotion 010. It's this biomarker called KIM1. So KIM stands for kidney injury molecule. And it's kind of intuitive when you think about it. KIM1 levels go up, for instance, post-op, when patients have had surgery and so forth. It makes sense, particularly after a partial, for instance, you see these levels surge because the kidney's injured, right? But what's kind of fascinating is that if we look at preoperative KIM1 levels, it seems to be predictive of outcome with atezolizumab. And KIM1, I think, is the one biomarker that we've got in this space which may potentially be worthwhile enough to take into the context of trials where we're trying to risk stratify patients for eligibility for adjuvant therapy. ctDNA is tough. RCC isn't a very high shedding tumor, if you will. So, certain tests such as the bespoke assays that sometimes we're using now in bladder cancer don't really have the same yield in renal cell carcinoma to date. That may change as we get assays that really have broader sensitivity. But for the time being, I think that ctDNA might be a challenging marker to utilize in this setting. Baseline genomic profile, I don't think really tells us particularly a lot in this context. KIM-1, I think, is really where it's at.
It's funny you mentioned that. I was just out in New York and Brian Shook gave a talk, and the title of the talk are Genomic Markers Ready for Prime Time at RCC. And he walked up and he goes, "No, that's the talk." Obviously, it was a joke, and he kind of went through all the data. But yeah, it is a little bit odd to me, too. These supervascular tumors, leaky vasculature. You would think that the tumor cells and the DNA has tremendous access to the vasculature, but it doesn't appear to be the case. And, with that being said, I think it was a paper out of Dana-Farber from 3 or 4 years ago looking at methylome profiling that actually had ridiculous data. Are you familiar with that study at all?
Yeah, and was it one that actually pointed towards KIM-1 or a different study?
I don't remember if it was KIM-1.
Oh, I know which one you're talking about. Yeah, I remember a Nature Medicine paper out of the Dana-Farber on this topic. Yeah, from Freeman's lab. Exactly, Tony Chouari was a part of that. Yeah, that sort of thing. So, as opposed to a bespoke assay, something that's relying on methylomics, which might really be highly sensitive in this context, that I think is a brilliant strategy for us moving forward in the field. And, I know that Tony and the gang there has some plans for that in the future. I just am not exactly sure where it's at in terms of clinical development.
Not to show the cards, but that kind of type of investigation has been something that I've been keenly interested in germ cell tumor land, where there's no reliable non-invasive detection test for teratomas. So something we're trying to kind of put together as well.
Totally. All
right, so we talked about the toxicity, we talked about restaging, and I hear you give them a balanced discussion of here's the cons, right? Here's the potential toxicities, and maybe not to make it overly black and white. If we look at the 3-5 year overall survival data, correct me if I'm wrong, the separation of the curves is something on the order of 6 to 8%.
Fair enough. Yeah, something like that.
And thinking out loud, when I started post-fellowship, peri-fellowship, chief resident, if you had muscle-invasive bladder cancer, it had to be neoadjuvant chemotherapy followed by cystectomy. And I still think absolutely that's a standard of care. And when I sit down with patients, I say, there's a study, there's 1,000 folks, 500 got surgery up front, the other half got chemo then surgery. And at 5 years, 10% more people are alive in this arm, and that seems to be digestible. And to be quite honest, over the course of my career, and I don't think it's just me, there seems to be this appreciation that we've gone a little kitchen sink, Halstedian to how do we become a little bit more selective? Do you think some of those, maybe upfront surgery, consider adjuvant, maybe chemo rads, which there's never been a randomized trial, but seems to have a possibly slightly lower clinical outcome profile. Do you think any of that kind of applies to adjuvant IO?
I think that question that you're asking is a provocative one. How do we kind of scale back, right? A little bit in terms of therapy. It's so tough because we've already gone there. We've demonstrated with adjuvant Pembro that you've got the survival benefit. If we were to sort of dial things back and say, hey, let's try to see whether or not there's some low-risk patients that can be spared, that becomes a very, very challenging trial to power and design, right? If we're focusing specifically on that low-risk subset of patients. We kind of see this in the context of bladder cancer, right? That I think we can learn a lot from the way that field is panning out. At least, in the U.S., I think it would be pretty unconscionable to do a study that didn't have an adjuvant checkpoint inhibitor arm these days, right? With the data we have for nivolumab there, one could argue pembrolizumab or not. But, what they've been able to do in bladder cancer is use the ctDNA approach, at least on the European side, right? Using, again, the bespoke assay and randomize patients to immunotherapy or not in patients who are ctDNA positive. And I think that's going to be an incredibly, incredibly informative study. So, there may still be places in the world where, perhaps the data is not compelling enough for adjuvant Pembro. I think those places are going to be harder to find these days. where there still might be room for an IO versus no therapy trial. I have a feeling that we're primarily going to be using biomarkers and other tools to escalate. So, for instance, if you have a patient who's KIM-1 positive, could they not just get pembro, but could they get a therapy on top of that, right? So I think that there's a lot of cool emerging approaches. We can talk about vaccines, targeted therapy, superimposed on pembrolizumab. All those might be the way that I see biomarkers panning out in the future. I think de-escalation is going to be a challenge.
Yeah, I mean, two comments. One, I completely agree. The second is, even like here, we have the modern study. Shout out to Tyler Stewart, one of my partners here. Really cool ways to escalate or de-escalate based on a reliable biomarker, which I don't think we have yet in kidney cancer. And I completely hear you and completely agree. And it's absolutely not our job to be paternalistic on what's best for the patient. I think it more behooves us to kind of share pros and cons and help them guide us in a decision. And so maybe we start with the low-hanging fruit. Thromboid nodes. Those are, if this was you, if this was your dad, this is your mom.
Yeah.
Dunzo. And maybe we can walk through some of the, in my opinion, slightly less compelling ones. I'm kind of showing my cards here. T2 with some grade 4 sarcomatoid, rhabdoid. What do you think?
Yeah. I think that's where the age of the patient really factors into things. I think you and I are both seeing a lot of really young patients being diagnosed with kidney cancer. And, if that patient, albeit T2 grade 4, is 45 years old, they've got a lifetime to accumulate the benefit that we see, in trials like Keynote 564, right? So those hazard ratios become, in my opinion, all the more meaningful. On the other hand, if the patient's 95 and has transportation issues, and we also see these patients, right? Because we're in areas of the country where, fortunately, longevity is almost a fact of life, right? So, I think that in those patients, maybe you might walk away from therapy. Some of the other gray areas for me are autoimmune disease, right? I have a lot of patients who in the metastatic setting, I have a pretty awfully high threshold for delivering therapy to already. When patients insist on getting adjuvant treatment in the context of autoimmune disease, I really balk, because I've certainly seen cases of, mild psoriasis or rheumatoid arthritis that didn't require, DMARDs for years, right? Really evolve into very, very sort of serious sequela once you start on immunotherapy. So in the adjuvant setting, I really have a very, very high bar for using adjuvant treatment.
Does that kind of similar mindset apply to a little bit of sinus fat or perinephric fat invasion?
Yeah, I think it's that exact same philosophy. It's age-based. I don't at all mean to be ageist here, but, I definitely think that, looking at Social Security, death indices and life tables and so forth, it's just a pragmatic discussion, right? What does that modest, 5-year survival benefit translate to in somebody who's 95 versus 55, right? It's a very, very sort of different equation for the two individuals.
And this is data that I just don't know. If you receive a nephrectomy and receive adjuvant IO and then go on to progress versus if you're a de novo metastatic that developed a MET, 6-8 months out, treatment options and outcomes, can you comment on that?
Yeah, this is probably one of the most challenging questions that's out there today. When you think about the data that we have in this particular context, it's minimal at best. Tony Schwerin and I recently published a study about a year ago now, CONTACT-3, which looked at cabo plus minus atezo. And it's really a trial that was intended to include patients post-immunotherapy. And we were thinking to ourselves, gosh, adjuvant pembro has been approved, at least, during a portion of the study. We had lots of adjuvant immuno patients who were on protocols prior. Ultimately, we only got a handful of patients, 5 to 10, who had received adjuvant immunotherapy going into the trial. The same is true for a more recent study, TNEVO2. So I think moving forward, that clinical space of patients who progress rapidly on adjuvant immunotherapy or who don't progress rapidly, who progress after some time, it's a huge unanswered question. So to the young investigators out there, if I were planning out a study, I would definitely try to tackle that space.
Yeah, and the numbers get small, right? I mean, fortunately, between surgery and adjuvant therapy, patients do pretty well. And this turns into the practicality of running a trial, getting patients like you kind of mentioned. And I mean, it's interesting. And I guess coming from like germ cell tumor land, there's some data out there that if you got like a cycle of adjuvant BEP for stage 1 non-seminoma and you were to recur, that maybe it doesn't look quite as favorable as if you were a de novo stage 1 that recurred.
Right.
So, one of the patient populations that you've been a huge advocate for is the non-clear cell histologies. And I share a patient with Renal, 36-year-old, huge HL-RCC, 30-centimeter big mass, couple of nodes positive. What's out there for these less studied patients?
Yeah, it's tough. I mean, specifically in the context of HL-RCC, I haven't seen a lot of great data for checkpoint inhibitor alone in that context in the metastatic setting. So I think that, we're kind of forced to lean on that, right, when we extrapolate it to the adjuvant setting. I don't know necessarily that there's a good enough argument. We think about, the outcomes here, right? I mean, certainly maybe that pembrolizumab is going to contribute to a decreased risk of recurrence. I hope it does, right, for a set individual. But what if it contributes to, an immediate autoimmune sequela of, having autoimmune carditis, right, at worst, or, maybe even a milder setting? What if it contributes to the possibility of said individual having lifelong chronic arthritides, because of the immunotherapy? So there's that spectrum of toxicity that I think we need to consider too, along with the potential benefit. I would love to see trials launched in the adjuvant non-clear cell setting. I love this podcast because you've already touched on two spaces that I think junior investigators can focus on. The post-IO setting, albeit small, it's one of those, really sort of unclaimed spaces in terms of RCC drug approvals, and non-clear cell RCC adjuvant treatment. Again, maybe even with non-clear cell metastatic disease, but those are two spaces where we really lack definitive evidence.
Well, I feel like when it comes to RCC, particularly, your wheels are spinning, and there's got to be stuff that gets you kind of excited about, whether that's advanced imaging or biomarkers or novel therapeutics. Can you share some of those that you're like, this could be like a game changer over the next years?
One trial I'm really excited about that is this study looking at V940. This is this personalized mRNA vaccine. We have the study up and running over here. I was talking to Raina. I think you guys might be in the process of opening that, I think, at UCSD, right?
I think so.
Yeah. So this is a vaccine that's actually generated from the patient's tumor. And it's really an opportunity to sort of elicit more neoantigens that lead to greater and broader efficacy from, for instance, adjuvant pembrolizumab. So the study's simple. Everyone gets pembro. It's a placebo-controlled study, so half of patients are going to get V940. And there's some pretty compelling data already published in Lancet Oncology in the melanoma space. The toxicity of V940 seems pretty modest. You might get some injection site reactions and some fevers. But other than that, I mean, great, from that perspective. So I'm really keen on seeing how that study pans out. And then, of course, I think we're all kind of keeping our fingers crossed that this trial of pembrolizumab plus or minus belzutifan reads out as being positive. So I'm not sure when that's due to read out, but that's another thing that could make waves. I'm more optimistic about belzutifan as adjuvant because that's a drug, that I think is far better tolerated than TKIs in many cases in our prior era of trials. And I think folks are going to be able to hang on to belzutifan longer than they were a year of sunitinib or a year of sorafenib.
Perfect. And, we've kind of touched on it a couple of times. I think biomarkers, just really selecting out the patients who are going to benefit and those who could probably safely be watched. Some of these new higher sensitivity imaging options, if you can get like a high quality CA9 PET scan and pick up a few things, predicting response to therapy. You kind of touched on that with KIM1. Clearly, it's super exciting, super complicated. There's host factors, there's tumor factors, there's the microenvironment factors, microbiome, which, again, you've done some pretty tremendous work on. Do you think these are all kind of pieces of the puzzle that we're going to be able to put together?
I 100% think so. I think if I were to look at the future state, for the disease, I think we're probably going to see, in a 20-year horizon, we're going to be able to check each other on this because we'll probably be at our retirement parties in 20 years celebrating together. But at that point, we should look back and see whether or not these predictions are right. I feel like we're going to have some microbiome-based therapy incorporated in either the frontline or adjuvant setting of renal cell. I feel like we're probably going to have some biomarker that we're using to allocate patients to therapy in that context. Maybe not to de-escalate, but maybe to escalate therapy, and I think we're probably going to see, hopefully at that time, a more idealized array of therapies for non-clear cell histology. I definitely think that we're probably going to have some area of focus on some of those untapped places that we discussed today on the podcast.
Well, Monty, I love it. I mean, your contributions have been awesome, from a cancer care delivery perspective, from a research perspective. It's awesome to kind of see the needle move and, not to sound like an old dude, but even like reflecting back on like my time as a urologic oncologist to see the tremendous progress that's been made. It's a total source of hope as I see it.
You're too kind, man. I always love listening to BackTable Urology. I always get some good insights from this program. So thanks for doing this.
Yeah, well, thanks for coming on. And maybe as we hit an hour, I think I could do another hour. You could share some of your kind of parting thoughts to the listenership.
Yeah, definitely. I feel like reiterating some of those untapped spaces is really key. So developing biomarkers to potentially appropriately escalate therapy for high-risk patients, developing strategies for non-clear cell disease, coming up with therapies for the post-adjuvant setting. That's really, really where we need to kind of band together as a community and focus our investigative efforts.
I love it, Monty. Well, thank you for coming on. Have a happy holiday season. And I'm a little bit nervous that with the cost of living here in Southern California, that 20-year retire might be a little bit optimistic, but let's see where the chips fall.
Good point.
Thank you so much for listening. If you haven't already, make sure to subscribe, rate the podcast 5 stars, and share with a friend.
If you have any questions or comments, DM us at _BackTable on Instagram, LinkedIn, or Twitter.
BackTable is hosted by Aditya Bagrodia
and Jose Silva.
Our audio team is led by Kieran Gannon, with support from
Josh McWhirter,
Aaron Bowles,
Josh Spencer.
Design and digital marketing led by Brian Schmitz.
Social media and PR by Chi Ding.
Administrative support provided by Jamila Kennebrew.
Thanks again for listening and see you next week.